The perceived weaknesses of endovascular therapy in the CFA have first of all related to durability. We have excellent long-term patency data for common femoral endarterectomy, but as the new kid on the block, endovascular treatment of the CFA just doesn't have that kind of long-term outcome data yet. A further Achilles heel, you can say, is the fact that the common femoral artery is the gateway to the vasculature for the body for so many other procedures, for cardiology procedures, structural heart, coronary angiography, and carotid procedures. And it's important to leave it in a situation where it can be accessed if it's treated endovascularly. It can later be accessed for any further procedure to treat any other territory within the body. There are several potential benefits that have been mooted for endovascular treatment of the CFA. The main one, I think, is that some patients who need treatment of stenosing or occlusive disease in the common femoral artery are really not very fit for a general anaesthetic, fit for open surgery. Their body habitus means that they may be at a higher risk of wound complications. And of course, with any open surgery, there is always a somewhat extended recovery period compared to a similar endovascular procedure. This patient is an 89-year-old female who presented to one of our satellite hospitals with bilateral painful lower limbs and a deep, large ulcer in the pretibial region of her right leg. She also had an extensive past medical history with multiple comorbidities, which included hypertension, hyperlipidemia, chronic obstructive pulmonary disease, chronic kidney disease, stage 3A, osteoarthritis, and restless legs. And she was noted upon admission to have an iron deficiency anemia and new atrial fibrillation. So clearly this is a patient with lots going on medically who may not be the best candidate for general anaesthesia. She also was noted to have restless legs and she had a high BMI. So again, this puts her potentially with the high BMI at a higher risk of wound complications after common femoral endarterectomy. So she had a CT angiogram, and it sent her into a little bit of an acute kidney injury as well, which again really does increase the risk for open surgery. And the CT angiogram shows extensively calcified disease in the common femoral artery of her right leg, with multifocal stenotic disease in the superficial femoral artery, and then a chronic total occlusion of her right popliteal artery. It was not possible to see exactly what the tibial runoff was doing on the CT scan, as her cardiac output was rather less, and we weren't able to opacify those well. So in patients like this with extensive tissue loss, I think it's important that they come off your angio table with inline flow to the wound. So we intended to treat the common femoral artery stenotic disease, but we knew we'd also have to recanalize this popliteal chronic total occlusion and make sure that we'd established inline flow to the ulcer. Now, her arteries were very heavily calcified, as I've said before, and this means that when you're trying to cross a very calcified CTO, it's better, in some cases it's almost mandatory to have access from the ipsilateral groin, so we need antegrade ipsilateral access. But her common femoral artery disease on that side was so extensive, it wouldn't be suitable for percutaneous access in the first instance. So my treatment strategy was first to treat the right common femoral artery using IVL, and then hopefully that would allow me antegrade percutaneous access to that artery in order to tackle the popliteal CTO head-on and get through that and stent it open. So in this procedure, I felt that IVL offered the best treatment option for the common femoral artery for a number of reasons. The first is that we could avoid an open surgical groin wound in this patient who, because of her BMI, because of her chronic kidney disease, and because of her poor mobility beforehand and just general tissue healing, would be at very, very high risk of a wound complication. The other benefit that IVL would offer in this patient is the speed of treatment. It's very quick to treat stenosing lesions with IVL, and even though we knew we were going to have to give this lady a general anaesthetic because of her restless leg syndrome, being able to do a quick treatment for the common femoral artery compared to open surgery and shorten that GA time really has demonstrable benefits for the recovery of older people after anaesthesia. The final benefit, I would say, is in terms of the profunda femoral artery. So she had an interesting quirk of anatomy where she had two profunders coming off the common femoral artery with disease proximal to the origin of both and disease between both profunda artery origins. So IVL is very, very safe in terms of distal embolization risk. So we know that we can treat both of those lesions without causing embolization into the profunda arteries, without having to jail them with a stent. And that means that hopefully, my plan at least was that I'd be able to access the common femoral artery straight away antegrade and go on to treat the popliteal CTO. My treatment strategy was to access the contralateral groin retrograde, which we did, and placed an up and over sheath. Angiograms confirmed the presence of the common femoral artery lesion, which we were able to easily cross. I then performed an intravascular ultrasound examination, which I like to do in these kind of cases to get accurate sizing of the vessel and also to provide a baseline to check for treatment success. The maximum size of the IVL catheter we have available is 8 millimeters, so that was the catheter we chose here. Now, interestingly, this lady also had some SFA stenoses distal to the common femoral artery lesion, which were also heavily calcified. So I decided to use the IVL catheter to treat those as well. Now, the IFU for the IVL catheters recommends an oversizing of 10% relative to the reference vessel diameter. But actually, with experience, I've become comfortable with a lot more oversizing than that, because we're not ever inflating the balloon to its nominal pressure. So it's very, very safe in terms of causing dissection, even using an oversized catheter in a small artery. And that has definite economic benefits, like we saw in this case, where I was able to use a single IVL catheter, 8 millimeter in diameter, to treat with 5 cycles in the 5 millimeter diameter SFA, and then the remaining 5 cycles which we used to treat the common femoral artery lesion as we'd originally planned. After treating the common femoral artery lesion, we then did a plain balloon angioplasty to 8 millimeters, and then I followed that up with plain balloon angioplasty and drug-coated balloon angioplasty to the SFA. So with the confidence from the intravascular ultrasound and angiogram images showing success of the common femoral artery treatment, I then felt safe to proceed to puncture the vessel antegrade to carry on with treatment of the popliteal CTO. And actually we could very much see when we were puncturing the common femoral artery that the IVL had clearly changed the compliance of the vessel, and we were able to easily access this heavily calcified artery with a micropuncture kit and place a 6 French sheath and move on to the next stage of the procedure. Now, obviously, with an antegrade access, crossing the popliteal CTO was actually relatively straightforward. We were able to re-entry to the P3 popliteal segment and place an interwoven nitinol stent. And the angiogram showed that actually below this lesion, she had 3 vessel runoff into the foot with a good wound blush seen over the area of the ulcer. So with this patient now, we have up to 6 months of imaging and clinical follow-up. Happily, her imaging follow-up shows that her common femoral artery in the SFA and the popliteal stent remain widely patent with really good triphasic waveforms all the way down the leg. Clinically, a lot of her rest pain disappeared immediately after the procedure. She still does have some localized pain around the area of the ulcer, which is granulating nicely. But the main thing is that we've achieved limb salvage in this patient. She's retained her independence and she's retained her ability to move around her own home and carry out her own activities of daily living, which I think is the most important thing in a patient like this. One of the Achilles heels of endovascular CFA treatment had always been considered the fate of the profunda. What would happen to the profunda? Was it safe from embolization? Would it be jailed by a stent? But actually, intravascular lithotripsy sidesteps these problems very nicely. First of all, IVL has been proven to reduce the need for bailout stenting, so the risk of having to jail the profunda femoral artery with a stent vastly goes down when you use IVL. The second thing is that IVL has shown itself to be very, very safe in terms of distal embolization. So when we're treating some of these common femoral artery plaques, which are often quite complex lesions, which are at high risk of distal embolization, actually with the IVL therapy, the risk of embolization into the profunda is very, very low. And it's for these reasons that I feel that intravascular lithotripsy really could be the final piece of the puzzle to safe, effective and durable endovascular therapy of the common femoral artery.